Should I start?
Yeah.
Yes. Hello everyone. My talk is on internal limiting membrane detachment in acute CRO. So the detachment of ILM as a biomarker in acute CRO has been described in recent literature. The proposed mechanism is that severe retinal ischemia leads to biomechanical changes, especially the Muller cell changes, which leads to this pathology, and this has been described as a poor visual prognosis. This study was a hospital-based retrospective case series, and patients other than other retinovascular disorders were excluded. All the patients underwent OCT macula comprehensive ophthalmic examination and 3-month follow-up. So to highlight, over 3 years out of 96 acute CRO patients, 6 patients had these OCT biomarkers, and all the patients had macular edema. The central macular thickness and maximum macular thickness were slightly different, as I mentioned over here. CMT was 492 and maximum was 687. I'll show in the next slide with the pictures. And most of the patients were young patients. If you can see this slide, almost all the patients are young males. So there is some gender predisposition also. Systemic risk factors, except one case, other cases we could not find any. Smoking was present in 50% patients. All the patients has very poor vision during presentation, which was there in the final follow-up also, except one patient which had a patent silvioretinal artery. And all the patients had macular edema. And interestingly, 2 patients developed stroke during follow-up. So this is the slide which we can see. Almost all the patients, as we can see over here, they had the internal limiting membrane detachment and macular edema. We can see this is acute CRO like OCT picture, hyperbolic inner layers are there. And the last picture, the right side lower picture, we can see there is a patent silvioretinal artery. So coming to the discussion, the ischemia of Muller cells leads to the internal limiting membrane detachment. But Muller cells span all through the retina, all of us know. Why not all the layers? At least in one case, we can see over here intraretinal fluid, and CME is also there in addition to internal limiting membrane detachment, which shows that maybe all the layers are also affected. But we could not see this finding in almost in all other cases. And second thing what we want to discuss is that all the patients presented with a very poor visual acuity during presentation, but if silhouette is patent, we can have a good vision, which was 6/12 in this case. And another finding is that this ILM, sub-ILM fluid, according to the 2 previous studies by Jain et al. And Venkatesh et al., they had told that it's a clear fluid, but in one case it was a turbid fluid is there. The exact cause I don't know, maybe some future studies will highlight on this. And another thing is the gender predisposition, as I told, the previous 2 studies, they have told there is slight male predisposition. Why exactly also needs to be answered in future studies. And systemic risk factors, interestingly, are less, we cannot find out in almost all the cases. So the limitation of this study is that it's a retrospective study, small sample size and limited follow-up, and the FFA, OCTA were not done in all cases. To conclude, ILM in detachment in acute CRO is associated with macular edema, probably resulting from the severe ischemia. Patients with poor vision and visual prognosis is bad. All the patients were male in this series. Not identified risk factor poses the other eye at risk, and possibly associated with increased incidence of stroke. Thank you.
Thank you, Dr. Chittaranjan. There's no hypothesis on why this happens, no?
Sir, what I could see, the previous 2 studies are there, 2 or very limited studies. They are telling that it is because of the Muller cell ischemia it is happening. But the counter thing is that if Muller cell is causing this, then why not all the layers?
Cases.
All the layers. So
it's very unusual, like ILM detachment in. What's the pathogenesis of this? Because various ischemic diseases, they don't have ILM detachment.
Yes, ma'am. Yes, ma'am.
Yeah.
So, but this is a this is interesting finding, and out of 96 cases over 3 years, we could find only 6 cases. So it's a small proportion of the cases that present with this.
Maybe this may be responding to arterial decompression surgically. There are some, I don't know, I'm just...
Yes, sir. In CRO, some surgeons have told about, in fact, last APVRS Hong Kong also, the award-winning lecturer was the Japanese doctor. He was given for the CRO decompression surgery he is doing. But in this case, we have not attempted surgical thing. And we have excluded all other things, like it is not a mixed or combined mechanism. That's why I highlighted that.
No, was there ERM in these? Because ERM, if it detaches...
No. It was ILM. We can go to that thing also. It is ILM Pakka. It's not ERM.
Thank you. Thank you, Dr.
Thank you, sir.
Sivaranjan.
Thank you.
Take-home message is send for stroke clinic. Many of us for CRAO, we send to cardiology evaluation. They will do echo and ECG and say everything is normal. But stroke clinic evaluation is most important in CRAO.